Kickstart the first topic on advising investigations. All of us are aware that we have many colleagues in the media, especially the National Daily, the Times of India, who love to write about the fact that doctors over-advise investigations. Then you have patients who say that I was under-investigated and hence my cancer was missed out. There are problems related to post-operative specimens not being subjected to the adequate histopathology or the histopathology which would really come to a diagnosis. There are many, many issues surrounding the investigations platform. The biggest problem today probably is that people have taken investigations to be a money-making racket. I do not have views on this. I essentially believe that evidence-based medicine is a pillar of quality healthcare. And if you do not provide evidence-based care and care that is recommended by textbooks of repute and organizations of repute like the surgeons associations, the medical associations, we would be doing the patient a disfavor. But that's an opinion which I'll keep to myself for the time being. And I'd like to invite the keynote speaker for today, Dr. Shankar Khobragade, as well as Advocate Vaishnavi Subramaniam. To introduce Dr. Shankar Khobragade, he is basically a member of the Maharashtra Medical Council from Mumbai, hails from Nagpur, honorary professor at the Nagpur University, and director of the Khobragade Multi-Speciality Hospital at Nagpur. May I please have Dr. Shankar on the stage, please? And I'd like to invite Advocate Vaishnavi Subramaniam as well. Advocate Vaishnavi Subramaniam is a lawyer at the Supreme Court. He's an associate of the medical legal attorneys. Advocate Vaishnavi, please. As I invite Dr. Shankar to give his keynote address, I would like to essentially state that we do intend running a tight ship in terms of time, and all comments are welcome, all discussions are welcome, but wherever we are overstepping and getting into a repetitive rhetorical mode, I will request you to kindly pay heed, and I will cut short certain discussions. Thank you very much. Over to Dr. Shankar Khobragade for his keynote address. Ladies and gentlemen, please give him a hand.
Good morning all. First of all, I'm very much thankful to the organizer, National Convention of Medicine and Law, especially Mr. Mahendra Vajpayee and the organizers. Thank you so much. The topic today given to me is advising investigations. As far as the investigations are concerned, it should be done judiciously and not in a routine manners. There are some casual approaches and some meticulous approaches. So what to do if the patient refuses for the investigation? There are some reluctant patients. At that time, in the clinical practice, it is found that how to handle with them. The said fact must be meticulously recorded in the medical records of the patient. Advise requisite investigation at the appropriate time. Time is very, very important as far as the investigations are concerned, and ensure that requisite investigations are not skipped and unwanted ones are not performed. So proper timing is very, very important in doing investigation of the patients. And what are the important life-saving investigations? Very life-saving when patient can die within a fraction of a second if the doctor does not advise the investigation like electrocardiogram, 2D echo, troponin T test, coronary angiography, in acute abdomen, ultrasonography. It is also possible applicable in pregnancy and acute cases. So what is this medical negligence? So there are some cases. I'm not going to discuss in detail all the cases, court cases. So delay in advising the appropriate investigation when indicated is also called as negligence. Failure to examine the patient is negligence. Sometimes the patients are waiting, he is getting chest pain and the doctors are busy in some other cases, and if the patient dies, it can be negligence. Delay in medical examination is also negligence. Don't skip required investigation and do not perform unwanted ones. This is a very important message, and due to contemplation, it is required advising the investigations. So, but in case of doubt, what doctor should do? Investigate and find the exact cause of illness. That is the basic duty of the doctor. And advise a second scan. Suppose the patient is coming with the one scan, you are in confusion state in X-ray. Any doubt on the first one, then record both and doubt and fact that second scan or X-ray has been advised. When to repeat the investigation? In case the referring doctor has any doubts on the reports of the scan, X-ray, MRI, then second scan, X-ray can be advised. So what is the rule of thumb in clinical medical practice? First of all, investigations are very important, from the basic to the advanced investigations. And there are something is better than nothing, because the patients, they are ready for the investigations, and most of the time they advise us that my ECG is not done, my X-ray is done, my MRI not done. Most of the patient, they are missed. When the patient of headache is coming and CT scan not advised, and if you miss the tumor, then we are in trouble. Sometimes the investigation like peripheral smear, most of the laboratories are run by DMLT in peripheral level, and I remember a case, the patient was diagnosed as a case of falciparum malaria, but in the advanced stage, after 1 month, he turned out to be the leukemia. There is a differential diagnosis. The best ways to perform or repeat the investigation rather than not doing so. It is the basic right of the patients, and it is the duty of the doctor. So if the patients complain that some patients they are having tendency to complain that they have been advised unnecessary investigations. But nothing is wrong by the court if the court is convinced that this investigation was necessary and it should have been done. So there is one patient who was advised HLA, and the patient said that HLA was not needed and it was unnecessarily done, but the court has given the verdict in favor of doctor. So what is advisable? Best ways to perform: repeat the investigation like important investigation like HIV in a case of PO or chronic diarrhea, hepatitis B, hepatitis C, and this in our laboratory, in our presence, because we don't believe in most of the time some other reports from the periphery. Can we withhold the results of investigations? There are some situations at that time you have to take the decision that you can withhold the decision of disclosing the investigations. Is it legally correct? Yes, withholding the results of an investigation for the therapeutic purpose for the confirmatory test is legally correct. But in practice, this may pose a problem if the patient persists to know the results, and caution is required, and decision to withhold must be taken on case-to-case basis rather than uniformity. It is not a uniform rule. Sometimes doctor has to select and give his own decisions. There is a case, in this case the court has observed that the gynecologist ought to have withheld the result of the blood test which shows a serious nature of the infection like HIV positive, and should have disclosed the result only after having confirmation tests. There are some tests, they are not 100% sensitive and specific also. Then repetition is also very important. So what about the option to the patients in choosing the lab? There are some labs which are run by 22, there are some pathologists. They are going to the pathology, 22 labs, there are some persons going, and there are only MD pathologists, they are not doing tests, but they are just doing the signing. Give options of a few standard. If the patient feels that that laboratory is very standard because of his previous experience, at that time he has a right to go there and get investigated. But that lab should be standard. Send the patient to standard lab is a rule, and final choice must be left to the patient with an increase in the tendency of the patient to view every advice for the investigation suspiciously. The aforesaid in fact becomes very mandatory. So what is the golden rule in practice? Don't rely on others' reports. Sometimes your ECG is done by juniors and he said that ECG is normal, but interpretation is very important. He can have EMI, he can have ventricular tachycardia, fibrillation, or so many arrhythmias. At that time, by seeing your own eyes and taking the decision is very important. So be independent, do it yourself. That is very important rule of practice. And because of dependency on others, there are some court cases, legal cases, because the doctors are so busy, they are going to so many hospitals, overburdened by the work. Do not rely completely on investigation reports of the other faculties. There are some other faculties, they are also sending some reports. So you have to take care that if you are not convinced, we have to get repeat investigation. Otherwise, it can be called as a negligence. Therefore, investigations are repeated. In case of the report from the substandard laboratories, investigation become rather mandatory. So what is the another golden rule of practice? Perform the appropriate investigation to arrive at an early diagnosis. If in case of brain tumor, or in case of lung carcinoma, or in case of colon cancer, adenocarcinoma, there are so many clinical conditions in which you have to diagnose early. So don't delay doing, because it can be called as negligence, and the patient can develop complications as far as the leukemia is concerned, Hodgkin disease. There are so many conditions. There is another court case In this case, the patient who had undergone angioplasty had intermittent fever with chills after the angioplasty, but the doctor said it is a routine and they have not advised the urine culture and patient landed into septicemia. So the court held there was delay in diagnosing this and it was found as a negligence. So what is the dictum in medicine? Old is not always gold. So always do fresh investigation, don't depend upon old ones. You have to repeat investigation on the day of surgery because there are some investigations they change like platelet counts or hemoglobin values or some ECG changes, they come on the day of surgery. So what precaution should be taken on the day of surgery? It is absolutely necessary to repeat certain investigation close to the scheduled time of the surgery or the procedure. Another court case, in this case, it was found that 11.2 gram about the hemoglobin was there 3 days before the surgery. But on the day of surgery, it was found only 3.1 gram. And the defense taken by the cardiologist that there was no reason to repeat blood investigation on the day of the surgery. As there could not be any drastic drop in the hemoglobin, he anticipated that hemoglobin is okay and performed the surgery. But there are some situations, there are some points, there are some conditions. So, but the court rejected the defense of the cardiologist, holding that not repeating test just before the surgery is called as negligence. Take greater caution in repeating the investigations. These are the very sophisticated, very costly investigation, modern investigation, and especially if the gap between the two is less. So don't believe on oral reports. Sometimes the patient say that my blood group is B positive and then the doctors, they land into trouble. A certain blood group of the patient by appropriate investigations and do not rely on the oral information given by the patient in this regard. So relying on oral information given by the patient is clearly permissible where certain parameters like blood groups have to be ascertained by the appropriate investigations. Advise the requisite investigation in writing. And if patient is not willing to get treatment, you can withdraw from the case and you have that right to refuse to perform the investigations or you can withdraw from the case. Advise the requisite investigation and the doctor always has the option to withdraw from the treating patient. There is a court case. In this case, the court in fact went to the extent of suggesting that if the patient had refused to perform the investigation as advised by the gynecologist ought to have refused to attend the patient, and this is a detailed case. Repeat investigation in case of doubt and if possible in another laboratory. Courts then draw favorable inference in favor of the doctor if the decisions are correct. Can we start treatment without investigations? There are some situations, the patient are coming in the emergency, some accident, some acute MI patients, and at that time you have to be in the hurry. So, but do not start treatment, perform procedure or surgery or confirm diagnosis without advising or pursuing the relevant investigation report. Starting a treatment, performing a procedure or a surgery, confirming a diagnosis, and also without advising the pursuing relevant investigation report is called as negligence. Is it record keeping very important? Yes. What is advisable? Make and preserve the photocopies of the investigation recorded on the thermal and chemical coated papers because after some days that ECGs are not readable. So investigation that can be recorded and perform requisite investigation at requisite intervals. Very, very simple investigation. And when you are advising, you have to take the holidays into account because we cannot give excuse that that lab was closed. So holidays must be taken into account while performing the investigations. There are some cases, he has stated defense that there was a delay of day in getting the report of the patient's CT scan due to the Dasera holiday, and this had hampered because if there is a coning of the cerebellum, patient can die in the sleep also. So record specifically if the patient refuses or fails to perform investigation along with the reason, if any, given by the patient for the same on his record. In this patient, one of the defense taken by the doctor was that he had advised an EEG, but the patient came back without getting it done and lied that the machine was out of order and concerned doctor was not available. So there are some excuses, these are patients. So perform requisite investigation to confirm the results of the surgery or the procedure, and failure to perform requisite investigation to confirm the results of the surgery or the procedure could be construed as a negligence. In this case, the court drew adverse inference against the orthopedic surgeon for not taking a post-surgery X-ray to confirm the results of the surgery. That's why there are some cases. So repeat an investigation, especially critical ones, if the reports are from other faculties. There is a case, court drew positive inference in favor of the consultant physician, as he had tested the patient for malaria thrice, even though an earlier blood test report brought by the patient indicated that the patient was negative for malaria. It is the decision of the physician. So repeating an investigation, especially the critical ones, even if the reports of the said investigations are brought by the patient, is always advisable. So take the requisite medically indicated steps in cases of abnormal vitals investigation reports. So abnormal vitals or investigation report that should be meticulously written in the, record is very important, and the court held hospital negligent for failure to take any step to investigate the reason for falling platelet count of the patient in this case. Perform the requisite pre-surgery test is also very, very important, and before the surgery, if investigations are not done, the patient may land into complications, especially the diabetic patient. Perform pre-surgery investigation, and if patient does not agree, then you have to mention it. Pre-surgery investigation must not only be done, but also duly recorded in the medical records of the patient, and ensure that once the sample is taken, sometimes the samples are taken, they are kept in the refrigerator, and after 2 or 3 days, the doctor is asking for it does not come. It reaches the laboratory at the earliest, especially in case of critical patient and emergency patients. So what precautions should be taken in blood samples? Samples should be reached earliest to the laboratory. And there are some cases. So hospitals and nursing home must ensure that once the sample is taken, it must reach the laboratory at the earliest, more than ever, in case of emergency and critical patients. So in this case, the court drew adverse infer from the fact that the blood and the urine sample taken from the patient who was critical at 5 a.m. reached the laboratory of the hospital at 6:43 a.m., almost after an hour and 43 minutes. Appropriate investigation must not only be advised, but also correctly interpreted. Interpretation of the investigation is very important and clinically correlated, because there are some histopathological reports if there is a benign or malignant falciparum malaria or a leukemia. So check the vitals and perform the appropriate investigation is important. Perform investigation on time. So hospital, nursing homes, they should have laboratory, or they should have tie-up with the standard laboratories. And failure to perform investigation on time is also called as negligence. There is a court case. In this case, the court rejected the defense of the hospital that they were unable to perform the requisite investigation as it was too late to send the specimen to an outside laboratory, since the nursing home did not have indoor facility. Advise and perform appropriate and reliable and more accurate investigation like MRI or some sort of histopathological investigation or electron microscopy. There is a court case. In this case, one of the allegations was that gynecologists had diagnosed preeclampsia based on a simple reagent strip test and not on the more reliable advanced pathological test. So failure to perform requisite investigation is called as negligence. So I'll summarize, because only 7 minutes was allotted to me. Perform the requisite investigation as per guidelines. It is always advisable to perform fresh investigation and simple investigation like ECG, blood sugar, liver function test, renal function test, thyroid function test, electrolytes, and blood sugar, very important. And it is advisable that perform fresh investigation rather than relying on the investigation done earlier. So in conclusion, advising the investigation, there should be relevant, repeat, urgent investigations are mandatory from the standard laboratories, and unwanted, unnecessary tests to be avoided as far as the clinical practice is concerned to avoid the medical consequences. So what is the take-home message? Medical practice should be done ethically and very meticulously, considering the legal aspect. All the legality, all the medical aspect, legal aspect, core cases should be understood by the medical colleagues, because there are so many colleagues, they are not knowing the law, they are only doing practice, and they land into trouble. So I think I'm finished, and I'm very much thankful for the listening to me. Thank you so much.
Thank you. So thank you very much for delivering an ab initio presentation as to what we are looking for. Ladies and gentlemen, we would like to have an open house discussion on some of the topics. We'll give Advocate Vaishnavi about 5 minutes to give a legal point of view on investigations. But before that, I'd like to extrapolate and take exactly 1.5 minutes to tell you what exactly is the view that doctors should be holding, according to me, as a CEO of a hospital. Essentially, investigations are to be ordered. All of us, if you remember our Hutchinsons, basically, we investigate only after we come to some sort of a differential diagnosis. First, we elicit history, we elicit morbidities, comorbidities. Subsequently, we do a systemic examination. We look at the symptoms like pain, tenderness, all of that. Once we've done that, then we come to a differential diagnosis, which is generally 1 or 2 or 3 in sort of medical entities, clinical entities that may be present in the patient. Subsequently, we look at investigations as a means of either affirming or negating a particular diagnosis. If we have a defined plan of care documented, that is our thoughts of what we were thinking of when we asked the investigation is documented, and if there's a clear rationale that we are asking for XYZ investigation because we have diagnosis A, B, or C in mind, then I think the courts also would take a reasonable view that you had a point of view which you were trying to exclude or include as part of the patient's diagnosis, and hence the therapeutic options available to the patient would depend upon that. That makes a lot of sense to anybody, and even the patient would then get convinced. If we are able to do this, then it justifies whatever investigations we are undertaking, rather than having for post-CABG patients, CT all, do everybody ABG, chest X-ray, electrolytes, creatinine. Doesn't make sense, you know. The other thing is there's this whole dilemma on viral markers that needs to get discussed and debated today, especially in light of the joint session that we're going to have later with respect to reuse and what is the legal stand on reuse. And there are different things, but one thing is evident: informing, counseling the patient at all points of view, at all points in time, with respect to what you're doing, why you're doing, withholding information. And I think if there is a concerted buy-in with the patient, I think the biggest C that we're lacking today is communication, because we don't communicate adequately. We keep getting hit with all these cases. Even if there is a mistake today, I know of doctors, hospitals who comfortably communicate this in a reasonably good setting with empathy for the patient without really getting into this whole business of discounting on bills. But despite that, they come out of it clean because they've kept the patient and or the patient relative informed at all times. So I'm going to give Advocate Vaishnavi about 5 minutes to come back with some sort of a legal standpoint on what we are discussing today, specifically with respect to advising investigations. And then I'm going to throw the floor open to all of you learned faculty. Advocate Vaishnavi, please.
Thank you so much and good morning. I'm going to keep this really general. So one word that kept cropping up during the presentation was medical negligence. Now, negligence is legally defined as a breach of duty to take care. Now, negligence stands proved when, number one, there is a duty to take care. Number two, you've breached that duty. And number three, a damage must result from this specific breach of duty. So now when you talk about negligence, it includes both acts whereby you have caused damage, as well as omission to do something which would have prevented damage. And these are acts that you've omitted to do, which any normal person, like a reasonable man, would have performed in the same situation. Now that's the test for negligence in a general scenario. However, when you're talking about medical negligence, that's obviously a lot more specific, because doctors are held to a higher standards. It is a more specialized field. So when lawyers deal with medical negligence, how to affix liability stems from one test called the Boehm's test. That's Boehm's law. So basically this is an English tort law, and it's used to assess medical negligence. So Boehm holds that law imposes a duty of care between a doctor and a patient, but the standard of that duty of care should be adjudged by a general community of doctors. So now what we understand is that the medical fraternity as a whole has to unite and decide that this is the bar to which we are holding you. This is the bare minimum. And from a legal perspective, it's essential that we arrive at this bare minimum with as much speed as possible, because once all the doctors know that this is my bare minimum, and if I perform this, I cannot be held liable in a court of law, you are now free to focus your energies on actually curing the ailment or the affliction with which the patient has come to you. Because it's very difficult when you're trying to cure a patient and you're asking yourself constantly, what is the standard of care I'm going to be held up to? What do I need to do? What do I not need to do? So your energies are not focused on where they should be focused, because you're also taking care, you're worried about whether you're going to be held liable in a court, whether your license is going to be revoked. And I really feel that there is a swift end to this problem, which just involves the medical fraternity. Like today, if we all come together and we decide that when it comes to advising investigations, this is the bar that we all need to hit. And over and above that, well and good, but this is the bar we need to hit. And once you have that goal in mind, your energies can now move on to curing your patient. And this is a win-win for everybody. It's good for your patient, it's good for you. I mean, it's bad for lawyers because we don't get to go to court as much. But I really feel that that's what we need today. And I'm going to just end it here. And my colleague who's going to come in the next session is going to elaborate on Boehm's law. And I think that we need to use this time to actually decide what is the golden bar when it comes to advising investigations. And I think that that should be our goal today, to come to some sort of an agreement on this. Thank you.
So, thank you. So basically what Advocate Vaishnavi is advocating is, please have a seat, ma'am, is basically to have consensus guidelines within the healthcare fraternity on what investigations should be asked for in terms of what particular disease presentation. So if you're presented with pyrexia of unknown origin, these are the investigations at a minimum that we should take. The unfortunate part is that we deal with the cross-section of society. Not everybody can afford everything, and that's why we unfortunately go on the back foot and say, isko ye afford nahi hoga, to isko aap chhod dijiye. Ye aap nahi kara sakte, to aap chhod dijiye. I think what is important is to document that we have advised it, and subsequently the patient has refused that. I think that is one important thing. The second thing is, we do have associations of specialists across this thing. I have my senior and very esteemed colleague, Dr. Utturi from Maharashtra Medical Council. If we at some stage through the Medical Council can work with these specialized organizations like surgeons, gynecologists, whether it's Association of Surgeons, FOXI, other institutions, and lay down certain consensus guidelines that these are the bare minimum investigations that we need to do, it might probably also help us to come to some sort of a consensus at some stage, because there is a third party involved here who is the payer, and at some stage the payer is also going to get involved in the medico-legal aspects of things. So this is one way in which we could look at this. But I'm now going to end my comments and invite Dr. Shrikant Shetty, who is a medico-legal expert of repute. He's a general practitioner and a law graduate. Dr. Shetty, for your comments, please. Dr. Shetty is known to be crisp in his comments, and he will respect our need to be quick and fast. Thank you, Dr. Shetty.
Thank you. Good morning. I am here to talk about medical investigation and how to avoid medico-legal hiccups. It has been found that it's a very thin line between proper investigation, excessive investigation, and less investigation. If you investigate as little as possible, you are found wanting in your diagnosis. If you excessively investigate, then people start suspecting vested interest, or they can, and it's always called, we got a new term which is called as defensive medicine. In this age of commercialization, proper investigation is required for a proper diagnosis. Whenever a patient comes to a hospital, the idea in coming to hospital is for a treatment. A doctor, when he examines the patient, he has a certain diagnosis, like Dr. Parag said, a differential diagnosis. Can I have water?
Can you have some water, please?
Based on the differential diagnosis, you order a set of investigation which is supposed to aid in your diagnosis. Whenever you investigate, there is a certain algorithm of investigation as mentioned by the textbooks. If followed properly, I don't think there should be a problem in investigating a patient. The problem with doctors is we write a certain investigation, but we do not write the logic behind that investigation on paper. We presume people come to know from the fact that you have ordered investigation. So the first thing I suggest for doctors is they should at least document the reason they are going for a certain investigation. In countries like India, where the cost of medicine is excessive, poor patients can't afford it, there are certain costly investigations which are required to aid diagnosis. Let's say for a CT scan. Based on a CT scan, you can decide between an ischemic stroke and a hemorrhagic, and that is the basic investigation required to treat the patient. Many patients cannot afford this investigation, and they try to avoid it. The doctor should at least mention the fact on paper that an investigation advice based on a certain investigation which was not got. If he can treat it, fine, but he should refuse treatment if the patient cannot be treated because of the lack of that investigation. In this age of commercialization, we have labs mushrooming all over the place. In a city of Mumbai, every gully has a lab nowadays. Many of these are run by, somebody mentioned, you have a pathologist who's attending to 22 labs. The problem with this is the pathologist is not going to be shortlisting or seeing the investigation personally. These are basically managed by unqualified professionals. In such cases, you don't know how to handle the reports, whether to go by the reports and treat the patient, or whether you have to go repeat the investigations again. In such cases, there are times when your whole treatment is based on the reports. Either you repeat the investigation. If the patient refuses, remember to document the fact that this patient has got a report from so-and-so lab and he has refused to repeat the investigation. Sorry. There is the problem of repeating of investigation. Patients come from some hospital, some other doctor. They would have come with a certain set of reports which you don't know whether to rely on. Or after a period of treatment, you tend to see the response of the treatment given by some other doctor. You want to repeat the reports. There are times the patient refuses to repeat it, stating he's suspicious of the fact that there are certain vested interests behind repeating the investigation. In such times, we sometimes tend to rely on those reports and continue with the treatment. This is a very wrong practice, because there are times when the doctor ends up in the soup because you don't know the quality of the lab which has done those reports. There are times also to see or assess the response to treatment, you would like to know a repeat of the investigation. Such things can be explained to the patient, but if the patient refuses, then please learn to document the fact on paper that so-and-so patient has refused so-and-so investigation in spite of repeated reasoning with the patient. We have labs, substandard labs, whose either misrepresented, wrongly labeled, like Dr. Parag mentioned, that these labs, they wrongly represent a specimen. We have got patients who insist they want to go to a particular lab with a specimen. You have a histopath specimen and the patient insists he wants to go to a particular lab. You don't know the quality of the lab. We tend to rely on such reports and we tend to base our treatment on the reports. There are so many patients of malignancy who turned out to be non-malignant. There are so many court cases which non-malignant have been malignant, but which has been held negligent by the court of law because the doctor refused to mention the fact that so-and-so was done by a so-and-so lab which was substandard, or he was refusing to accept those reports. There are many times we have seen patients who withhold reports. Many reports, like you have HIV reports, patients' relatives withhold the reports. In such times, you would have investigated the patient, you would have been treating, somebody else would have treated the patient. Many times even the treatment of other doctors would have been withheld from the doctor treating the patient at present. And these reports happen to turn up in a court of law. Such times, at least mention the fact that so and so had come on, so that at least the history should be proper, and the investigation protocol or the reason which you have written the investigation, please be mentioning it on paper. There are times the patient subsequently shows the reports which has already been done and you have asked for it. Such things should be clearly mentioned on paper that so and so report had asked for a few days back, but the patient subsequently has come with a report which has already been done. This has been withheld from me by the patient.
So, 1 minute if you wind up.
Yeah, just 1 more minute. Last, before I finish, we have a problem with similar sounding names. Anil Singh, Anil Yadav in Maharashtra, Lakshman Patil. Many labs have 2 or 3 patients of the same name on the same day with the same investigation. And you tend to misplace it, or some patient ends up with, see, the investigation reports are handed out by the clerk who may not be quite educated. Here the problem is, that is always, so please remember to at least have extra information on the name and against the name. If possible, at least have some identifying marks so that you don't have a problem with misplaced reports or some report going to some other patient. And last, before I close, there is a story I heard, how do you name a Chinese baby? They said you drop a set of cutleries and the sound which sounds the best is usually the best name for the child. The reasoning I am mentioning is this: most of the Chinese names end with a ling, ing, ting, ping, ming. So I keep wondering sometimes, supposing we have so many problems with Anils and Sunils and Lakshman, what the Chinese must be facing medico-legally. Thank you. Thank you.
Thank you, Dr. Shetty. So I'm going to alternate the doctors and the lawyers so that none of us feel left out. I'm going to invite Dr. Alok Kanugo from Bhubaneswar, who's a diabetologist, chairman of KIDS Hospital. Dr. Alok Kanugo, for your comments, please.
Can I have these slides, please?
So please continue.
But yes, I have a small presentation, maybe for a minute. Can I have that slide, please? My previous speaker has discussed a lot about do's and do nots on medical investigation and how to advise that. Being a diabetologist, I face a very common problem regularly. To others, diabetes is a blood sugar disease. And to me or to us, diabetes is a multi-organ disease, and it is a vasculopathy, means affecting all blood vessels and all organs of our body. When patients, the previous tradition was people were asked to do fasting blood sugar and postprandial blood sugar, and they were extremely happy with that. Even today, professors of medicine ask for fasting blood sugar, theek hai, so you are all right and you go back. When we ask them that you need at least annual checkup for your whole organ body checkup, and you must know how your heart is, how your kidney is, then things become different and people don't accept it. This is a friend of mine who was an orthopedic consultant at Bhubaneswar. He asked vitamin D investigation for a suspected case of ricket. The patient's father was poor and maybe mentally unstable. Few days back, he spent 2,700 rupees for the test, and few days back he came with a bouquet and a bag and killed the doctor. And the cause is why he advised so costly investigation to a poor man. Things have gone to this extent. And this is the real life camera shooting of how he killed him. And the police commissioner is justifying, and this is a case 6 months back in my city. This is another incident in my city where people ransacked a nursing home because the investigation was delayed and the patient died. And that was a medical negligence that the people conceived, but the doctor was almost into the deathbed, then he recovered. The people have already taken law into their hand. So medical doctors have very few choice now. They should be protected. If they are in corporate setup, they are protected by the corporate group. But at the individual level, they compromise with what people think, not what should be done. Many of the medical problems, if you investigate properly, you can treat at least maximum 80% of patients. 20% of people will not be cured of their problem, and 5%, 10% are definitely going to die. There comes the problem of negligence. People do not want to accept death as an ultimate of any treatment process. If somebody fails in legal procedure, the other party is not coming and killing the lawyer. He is never doing that. But we are accessible, approachable, and available for torture by the patients. So this has really become, in the last few years, it has become a concern of physicians. You must be looking at many ICU doctors are beaten, harassed, thrust regularly in different hospitals of the country. This has become so regular a practice that if the patient dies, the institution has to be broken and doctor has to be harassed. So the rules that different courts, my previous speaker so nicely deliberated, have gotten a lot of importance, that if the patient doesn't want to do investigation, please do record it. It is a negligence on the part of the patient, not on the part of the... Before the surgery, please do the investigation on the previous day at least. Maybe a 7 days old report, that will never protect you in the court of law. Must do it on the previous day. If you think that there is a repeat scan or X-ray is needed, please do it. You are legally protected. If you do not do, you are more neglected. You will be affected by law for neglect. So these are the things we must keep in mind. And as physicians, as doctors doing practice, we should know more about the law. What are the rules and what are not rules, which most of the doctors do not know. This is a wonderful forum which has come forward to educate both the communities, and that will really go a long way in helping our patients. Thank you.
Thank you very much. That was really crisp. I'm going to invite Dr. Mukesh Yadav, Professor of Forensic Medicine and the editor of the Indian Academy of Forensic Medicine, moderator quality of medical education, to please come up. I request you to keep your presentation and discussion to about 3 minutes, because I really need the open house to open up. Because otherwise we will just be a plethora of lectures, and that's not what you're here for.
Thank you, Dr. Parag, for giving me an opportunity. Most of the things have been already discussed by the previous speakers. My just concern about the legal and the gap between the medical and legal aspect. So who will decide what is needed in that particular case or what is not? Obviously the answer with the treating physician, attending physician. He is the best judge, and what should be the test for that? What is the best for that patient? The answer which every doctor must ask before prescribing or not prescribing, able to justify why you have not prescribed or why you have prescribed. And from the patient point of view, from the negligence point of view, when it becomes negligence, when there is a damage only. And what is damage from the patient perspective, not from the doctor's perspective. Whether it is costly, when the same investigation is with some other hospital or doctor, it is less, because market rate is going to play an important role in that aspect. So damage in two aspects, whether financial damage to the patient or actually some bodily or death of the patient. That is usually concern for the doctors. So you please keep in mind your knowledge, your experience will play a great role, and the guidelines, SOP, maybe by an ABH or in that particular locality where you are practicing, or the Bolam test, open thing. You should be fulfilling minimum one. But if you are always trying for minimum, you will nowhere in the business, because another colleague may be trying to give best with the same price. So here you have to make a balance and keep aware yourself. Thank you. I think this is more than enough.
Thank you very much. Thank you, Dr. Yadav. May I invite Dr. Bhaskar Shah to come on and Do we have Dr. Bhaskar? I think I'm going to throw the house open. I would request you not to get into repetitions of what our esteemed speakers have already spoken, because all of us, I'm going to just reiterate it once. One is documentation of refusal of patient to go in for certain investigations. If you feel that it is life-threatening, I think it is time to turn the patient away and to tell him that if you are not going to do this, I'm not going to be able to treat you. The second one is disclosing and withholding information. That's something which we need to be very critical of. Doing investigations which are truly necessary and for which you as a learned professional have got a clear idea as to why you're going in for that investigation. Repeating investigations wherever you feel it is relevant. Repeating an HIV investigation which is seropositive and confirmed by the confirmatory test does not make sense. But repeating a hemoglobin on a day prior, if a report is 7 to 10 days old, makes a lot of logical medical sense. And I'm sure the lawyers would also agree with that. Provisional reports wherever required, not delaying the issuance of provisional reports. Of course, beyond doubt is the requirement of the identification of the patient. The NABH standards, Joint Commission standards, Australian standards all talk about 2 unique identifiers for every patient sample, and I think that's something which we should definitely be looking at. Mostly, I've audited about 50 hospitals in Delhi, and not to speak bad about the capital, but in the capital, unfortunately, everybody writes only a single name, Miss Sangeeta, Mr. Papu. So I think the full name is relevant. Surname is important. Wherever the name and the surname is the same, in case of 2 patients, it's important to even write the father's name as applicable. The UHID or the IP number, whatever is selected by the healthcare organization, is important. We discuss potentially to look at consensus guidelines for certain investigations in the majority of cases that come up to our hospital. And once again, I repeat, I cannot repeat it often enough, is the documentation of refusal of a patient to undergo certain investigations, so that you as a medical professional, though it may not hold up in a court of law because you are the learned professional, he is taken as a lay person. So these are some of the points which we've already discussed. I'd like to throw open the floor for new points that come up, only because we are running a tight ship and we'd like to get on with the next topic also of taking history. Ladies and gentlemen, over to you. Can we have some mics circulating, please? Kindly identify yourself, state the issue that you'd like to discuss, and your learned colleagues will contribute, sir. Lawyers, doctors, all of us are in this together. Okay, please. Sir, second row, please. So the mic will come to you.
I think we have discussed, and it is well summarized by you. And I'm Dr. Mahesh Baldua. And what we have not discussed possibly, or may have discussed lightly, are the patients we take for investigation on a particular point, and you ask for repeat. But there are patients who go downhill. They may be having comorbidity, new complications coming up. So we need to be aware, and we need to investigate in that direction also. So there are cases to that effect. I can tell you about Poonam Verma versus Ashwin Patel, where they totally forgot to investigate. They concentrated on fever and his problems. Whereas the patient was having diabetes and he went into diabetic ketoacidosis and died. So many times the comorbidities also do come up. So someone has discussed this.
Which, Dr. Baldua, will also come up in our second discussion on taking history. Do we really take history on the relevant comorbidities, India being slated to become the diabetic capital of the world? Are we really focusing on those comorbidities enough? That's a very relevant point.
In the same way, the disease also changes the course. Every disease does not behave, it has a natural course. So many times we forget, and it may not be even treated as we like it. The other point which I would like to point out to Dr. Yadav Saab, that there is something like, okay, when a person is alive, investigations are fine. But what about post-death? Biopsy is allowed. Blood investigations are allowed post-death. Imaging investigations are allowed. And if they are not allowed, why they are not allowed?
I think all of us agree that when a patient is dead, he is dead. Any such interest that may come up will be purely for academic interest, in which case you must take specific consent for that after declaring the death of the patient. That is something which is done, especially in forensic medicine, where we are looking out for, and that is generally documented as what we call a forensic postmortem examination.
So many times, like liver biopsy, bone marrow. I want to do some certain blood tests. There will be, if a patient dies suddenly, there will be so many things which will be hurled on me, the poisonous injection, expiry date things, the things were not done, things were overdone. Now how do I prove it? Unless we have a blood or serum or plasma or some imaging investigation. And each time postmortem is not possible. Each time. And even the postmortem is done, you will agree with me with what standard it is done and with what motives it is done. And last, if you don't want to discuss, we have not discussed about the kickbacks. I think that is one thing which is important.
So we need to involve one more association here, the Institute of Chartered Accountants of India, probably.
Yeah, good
Sir,
morning.
I'm going to take 5 questions and 5 points because otherwise we will not be able to move ahead. Yes, sir.
Good morning. I'm Dr. Sunil Khetarpal. I'm working as a group CEO with Shelby Group of Hospitals based at Indore. We have been discussing about the investigations to be done in routine cases. But what about the investigations to be done in medical legal cases? When we register a patient as a medical legal case, you are advising X-ray or blood test. See, X-ray, sometimes the X-ray film is required by the court of law. Then if you hand over the X-ray report to the patient, so what protocol should we follow? Whether we should be doing 2 X-rays or we retain the X-ray with us, we do not hand over because it is the right of the patient. If the patient has undergone the investigations, we have to hand over all the reports and investigations to the patients also. So in medical legal cases, investigations to be done, what protocol we should follow?
We'll discuss that, sir. We'll come to that. Thank you, Dr. Khetarpal.
I'm Dr. A.K. Grover. I'm an ophthalmologist in New Delhi, and I represent All India Ophthalmic Society here. I'm a past president of the association. We have discussed the various variables which make the SOPs difficult, like the wide spectrum of conditions, like the wide spectrum of individual experience and so on and so forth, and training of surgeons, doctors, etc. But the one variable which we haven't discussed so much is the factor of difficulty in maintenance of documentation and curtailing the costs when the treatment is given at different levels. We are talking about maybe metropolitan cities, when it is done in smaller cities, when it is done in taluks, when it is done at village level. And the cost involved, the amount that the patient can pay is very variable. And if you expect a documentation of the highest standards, you need staff, you need to maintain those records with a lot of effort and money put into it. Now that variable means that you need to be providing first world level of documentation for medical legal purposes with third world costs or third world refunds to the doctor, which means a doctor in a taluk or a small city needs to handle 100 patients in a day in order to run the hospital, because his costs or reimbursement per patients are maybe about 50 times lesser than what he gets in US. So those factors have to be factored in the entire picture.
So I'm going to separate a little bit of, I won't use the word wheat from the chaff, but I'm going to separate your question and your dilemma in 2 pieces. One is on the documentation. I think this entire body believes that what is done must be documented. What is not documented is considered by anybody as not done. And I'm sure the courts of law would take a similar kind of thing. If you say you've done it, it's one thing to say I've done it. There was a code and in an emergency I could not document, but I documented post factum. But documentation of some sort, however rudimentary it is, paper is always available even at the taluka level. The second part on the cost I'm going to keep out because it does not concern this body today. But I accept one point, documentation is important, must be done. The courts are not going to accept anything lower than a particular level of decent documentation. A pen and a paper is something that is exceedingly cheap. I'm going to pass it over to this side. The lady, ma'am, I don't want to be subjected to any gender discrimination biases at the end of the day. Ma'am, please, sir, I'll come back to you.
And I've come from Pune. We all face this problem when we are doing fast tracking. We are all now being pushed into getting patients on the day of surgery and getting them out by the evening. Now, when we go and see our patients in the morning, I don't think anybody has a choice. The patients have come bringing documents from outside. We have to rely on them. And they may have been done because it's a routine case or whatever, 4 or 5 days, maybe even a week or 10 days. And like Madam says, we have to put down some kind of guidelines which says we will accept or we will not accept these investigations. And fast tracking is something that we
it's
all
bound
have
to happen.
get.
I think with the cost spiraling, we are going to face this. May I have a lawyer's opinion on this, please? Esteemed lawyers, I'd like to hear you, please. May I have a lawyer's opinion on this? Does a doctor have a right to say, I will not, to another doctor colleague of his, I will not take this patient up because this patient needs to get investigated. I'm not willing, is that the question?
Yes.
I'm not willing to take a particular
10
type of thing beyond this. I think the nation needs to know, sir. So can we hear it, please? Can we have some of our lawyers talking about this?
Your surname is not Goswami, is it?
No, sir. Advocate Bajpayee, maybe you'd like to comment? Sir, we're just trying to keep a certain level of optimism and pep.
Thanks. As far as law goes, we have two sources of law. One happens to be the written law made by either MCI or the Government of India. And the second happens to be the law that comes from the court. Precedents, judgments. Unfortunately, on this question, neither of them have said anything. So a doctor can refuse to accept a patient for any reason, except on religious grounds. But whether on investigations he will be able to exercise that right, it's a big question mark. In the grey zone, Dr. Parag.
I'd just like to say one thing. I think this is a matter of dialogue between physicians, between anesthesiologists and surgeons. If you're not comfortable, you don't give anesthesia. If you don't give anesthesia, he can't operate. And I think surgeons have to understand that it is the anesthesiologist who's the captain of the ship in that OT. You're not going to cut till the anesthesiologist says go. So I think it's up to your better judgment because you're responsible for salvaging that patient life. The surgeon is only going to remove or do something with the patient. You're responsible for the patient's physiology and whatever happens. So I think we've answered that. Madam, if you're a lawyer, I'm going to give you a chance. Yes, madam.
I'm anesthesiologist and LLM. I'm a lawyer also.
Okay, so then we'll take you as the lawyer on this 5-question forum. Okay, sir, ma'am.
So the thing is, first comment on what you just now said, that the surgeon will not operate if the anesthesiologist doesn't give anesthesia. It doesn't so happen. Okay. Somebody else would come up and do the case. Now, the second thing
That's also an anesthesiologist.
Yeah, that's also an anesthesiologist.
So fraternity.
This is just a part of day-to-day experience that we have. Now, secondly, I personally feel, yes, if I'm not comfortable with certain things, certain investigations, and if it's not a life-threatening situation for that patient at that moment, then I can walk out, saying that, no, I'm not going to proceed with any kind of treatment unless I'm comfortable. And investigations should, as far as possible, may I humbly put, that we get them done only in standardized labs which are monitored personally by qualified pathologists only, leaving apart the cost factor that can always be negotiated and managed. Because if we put ourselves into the patient's shoes, our entire treatment is based only on the reports which come to us. Now, if these reports are not reliable or worthy, the entire exercise is a failure. So kindly stick to standardized labs.
This gentleman here in the third row, please. And I'm going to take sir's comments, and that will be the last comments.
I'm Dr. Kedarnath, maxillofacial surgeon from Bangalore. So my point is regarding investigations. The differences between the general practitioner and the specialist on the same procedure, regarding the same procedure, the difference in the investigation. A general practitioner might opt for few investigations, whereas a specialist might opt for few more. There are no guidelines, particular guidelines. These are the minimum guidelines that is required. To say a very simple thing, so I also represent a dental field. So for a simple tooth extraction, a general practitioner might say few blood investigations like hemoglobin and other things, bleeding or clotting time or prothrombin time. Whereas a maxillofacial surgeon, he might say take a OPG, a X-ray of the jaws, because there might be a central hemangioma. It can be which can even, after removal of a tooth, a death can happen on the table itself. So there are no particular guidelines that these are a must for this particular procedure. I think through this forum, I request the things to be go to each association, that particular specialty, where for particular procedure, these are the bare minimum investigations that are required.
I think we will work closely with the medical councils. We have good senior representation here of some medical councils to do that. Sir, can we have the last thing on this particular topic, please? Sir. So yourself.
Actually, the point has been made by my predecessor. But one point, I think we could also educate the patients and the lawyers and the doctors ourselves that medicine is a very imperfect and imprecise science. Therefore, there are gray zones more than black and white. And that is what can actually be addressed in various guidelines and various protocols that need to be fixed.
Essentially, so to sum up, I'm just going to take this off because we have another topic and we do need to close by noon. Dr. Utture, I'm going to give this. Maharashtra Medical Council is something that has a valid voice, and being in Mumbai, I cannot afford not to give Dr. Utture the mic, please.
Just 2-3 comments on what has happened over here. As far as anesthesia is concerned, I just gave a talk for anesthesiologists, your association. You have a right to refuse the patient. Remember that. No surgeon can force you to do that if you have valid reasons, unless it is an emergency life-saving procedure. That is their bottom line. As far as what investigations have to be done, not done, and then being held legally wrong or right, we have been trying to push to the government from our side also of the concept of having a medical tribunal under all the state councils. Because, as they say, the minimum bar, what everybody is talking about. Remember, from patient to patient, that minimum bar differs, depending on what is the patient. For the same problem, if it's the same, I'm a surgeon, if it's a hernia, for a 20-year-old patient who is otherwise normal is different, but if he is diabetic, the bar is different. So it is extremely difficult in medicine to have that bar, because in medicine, 1 + 1 is never 2. It can be anything. So instead of that, the ideal thing would be, what we have been trying to push to the government is that we should have a medical tribunal, which whenever there are such cases by the court should be referred to this medical tribunal, because there in the medical tribunal, which is set up by the council, you will have experts in that particular field. Unfortunately, today what is happening, at least in Maharashtra, what is happening is these cases are referred to the government medical colleges. One thing you have to understand, that how a person works in because I am working also in JJ Hospital as an honorary. What we do and work in a government medical colleges differs a lot from what we do in the private setup. So, and that is the reason why we have been trying to push that the council should form a tribunal with experts in that particular field. Because as a surgeon, I cannot sit in judgment to what an anesthetist does or what a physician does, a diabetologist does. So we can form that. So I think since you're coming out with some white paper, you can put that down also, of pushing for a medical tribunal by the state councils.
Okay, I think that kind of sums up. I have one question from Dr. Vora Preetham, which I'm going to take for lunch, because we need to have a good networking lunch also. We will discuss this, Dr. Vora, at some stage during lunch. I'm going to thank all the participants for the first part of this main session. Thank you, Advocate Vaishnavi. I'm going to request you to step off the dais, and I'm going to request the next group of people. Taking history is the